Welcome, everyone, to what I believe is going to be an extremely interesting webinar talking about the latest therapies and data with regard to mitral and tricuspid valve disease. I am here with an absolutely superb faculty, and we will go through the various devices that are available now for both mitral and tricuspid disease. And before we start, maybe I'll just quickly introduce my colleagues on this webinar. First, I'd like to introduce Dr. Becky Hahn, who's the Director of Interventional Echocardiography at New York Presbyterian Columbia Hospital. We also have Philippe Lurs, who is a Professor of Medicine at the Heart Center in Leipzig, Germany. We have Dr. Azim Latib, who's the Director of Interventional Cardiology at Montefiore Hospital, and Dr. Scott Lim, who's the Director of the Advanced Heart Center at the University of Virginia. So obviously surrounded by some of the best experts in the field, and we're going to start off with Dr. Becky Hahn to give us sort of an overview, comparing and contrast some of the challenges in imaging the mitral and tricuspid valve. Becky.
Great, thanks, Mark. I really want to thank CRF and you for inviting me to talk about my passion here, which is obviously imaging the mitral and tricuspid valve. So, when we talk about what to do about mitral and tricuspid, we refer now to this expert consensus decision pathway, and it's really clear that early on, the imaging expert has to be consulted, and then obviously the patient moves on to the multidisciplinary heart team. But imaging is pretty nuanced, and so this is our grading scheme for mitral regurgitation, and it really does take an expert in echo and with particular interest in valve disease in order to quantify the severity of regurgitation, which is now required really in getting patients into trials and in justifying intervening on them, understanding again that there are lots of nuances. But the tricuspid's even worse. I mean, the trouble with tricuspid is this variable anatomy. And so you can see 2 leaflets, 3 leaflets, 4 leaflets, 5 leaflets. We've seen a 6th leaflet. These are patients that are very complex, and their regurgitation is also really complex. So it would be hard for us to believe that we could rely really just on a single measure of quantitation, which in our guidelines is just the proximal isovelocity surface area. And that has a lot of assumptions. That assumes that that the leaflets are flat, that the orifice is approaching a flat surface. It assumes that it's a circular orifice and not a crescent-shaped one like the one we see here. And again, you can see that it's not a hemisphere, but a hemiellipse with a lot of temporal variability. And so we've come up with a lot of new quantitative measures of the severity of regurgitation, which I think will be very useful. And from our core lab, we've looked at a number of these patients and shown that the PISA actually underestimates significantly, or is significantly smaller, let's say, than the other measures like 3D vena contracta area and Doppler effective orifice area. So we do believe that there's a relationship between them, but that for tricuspid valve, we so frequently have a crescent-shaped lesion that it's almost a 1.8-fold difference between the EROA by PISA, which underestimates the severity, and then that by 3D vena contracta or quantitative. And so the patients that we see are the ones that you see on the left here, where they have massive, this happens to be an atriogenic functional tricuspid regurg patient. And so we designed an extended grading scheme to help describe the patients that are coming to trials and that are getting these new devices that you'll hear about with the other speakers.
Becky, could you describe what you mean by atriogenic TR?
Yeah, so these are patients that typically have chronic atrial fibrillation. You'll see a couple of examples on the patients here. And about 80% of the patients coming to trial have atrial fibrillation. And that is a stimulus for dilatation of the right atrium and then the annulus. And when you dilate the annulus, then the leaflets don't coapt in the middle anymore. And you have what we call atriogenic functional tricuspid regurg. It happens, it was thought to be only about 10% of the patients that are coming to trials. but it's really a lot more patients. Maybe our other speakers also have a lot of experience, but we're seeing a lot of atriogenic functional tricuspid regurg.
So Becky, a little bit like this CAT scan you're showing you on the left with this really huge atrium, the annulus dilated, but actually quite a small right ventricle, right?
Yeah, and they're particularly, difficult to, you've got a lot of space to maneuver in, which can be good and bad, so depending on where the IVC actually enters in and how it's deformed the IVC, since that's typically how we're introducing many of the devices. We already
just
have
one more question quickly, Becky. The leaflet anatomy, is it more horizontal in the atriogenic, or do you still get some tethering as you would when you have RV dysfunction?
Yeah, I mean, you can have a mixed disease for sure,
Okay.
but often in a pure atriogenic, it'll tend to just have dilated the annulus, and the leaflets are pretty much coming to the annular plane. But
Okay.
so frequently, you begin to then get right ventricular dilatation. Once you get right ventricular dilatation and the papillary muscle is pulled out, now you're going to start to see the tethering of the leaflets as well. So, I mean, I think, again, most commonly, it'll be a mixed disease where you'll see a lot of annular dilatation as well as tethering of the leaflets.
Great.
So we already have two manuscripts, two papers. I'm only going to show you the most recent from this year that has validated the extended grading scheme. And this one comes from Jan Topilsky's lab, where you can see with this spline analysis that there's a cutoff, and these are all PISA-derived EROAs. And so as you saw with our study, 35 was the cutoff for severe, and they found the same thing. 35 is the cutoff by PISA for severe. And then there's another inflection point on the spline curve where there is what they call torrential. Now this ends up falling in our massive range in the grading scheme. And we go on, and I'm sure all of our speakers have also seen this, but they go on to 2 and 3 and 4 centimeter squared regurgitant orifices. So there's another grade beyond that as well. And whether or not the grades are important, I think, has been really shown by many of the trials. And this happens to be the late breaker that we presented on the Triluminate trial at EuroEcho Imaging, where we showed that if you use the current 3-grade scale of just mild, moderate, severe, that you ended up having a lot of patients that you can see here that stayed in the severe range. And so, you put the device in, you put the Triclip in, and they were still severe. And yet you can see 86% of them had a significant improvement in New York Heart Association class. But if instead you use the 5-grade scheme, where you now have severe and then massive and torrential, you can divide those patients into the grade reduction. Was there a single grade reduction, 2-grade reduction? And now all of a sudden it becomes much clearer that the 2-grade reduction had 93% of those patients end up being at New York Heart Association class 1 or 2, versus the patients with only 1-grade reduction, where you have 74% of the patients in New York Heart Association 1 or 2. So again, we believe that the grades are important. We believe that a 1-grade reduction is still associated with significant benefit, but obviously a 2 and a 3-grade reduction, even if that patient still remains at severe. So a 2-grade reduction from torrential to severe still sees significant clinical improvement.
So maybe I'll just pause you again there and maybe ask Philippe a quick question. Dr. Lurs, when you're doing these procedures, are you usually satisfied with a 2-grade reduction maybe after 2 clips, or would you proceed even further to add a 3rd clip to try to get it down to mild to moderate?
It obviously depends a little bit on the anatomy, and in some cases we are happy if we can get it down by 2 grades. But if there is a possibility from an anatomical point of view to get it down even further, then we certainly would try that. I mean, there are a lot of papers out there trying to find the best predictors of clinical benefit, and there's a signal there and there. But the strongest signal so far we've seen was really the amount of TR reduction. And if you have a successful procedure, then there is almost no doubt that these patients benefit from a clinical point of view. So our approach would always be to bring it down as much as possible.
Perfect.
maybe Scott, I mean, isn't this, you know, what we've been trying to do with mitral as well? That the greater the reduction, the more the benefit for the patient. So we should be trying to get the best possible reduction in regurgitation.
You know, it's a good question. I think it actually, there's some additional complexity on the tricuspid side compared to mitral. I think mitral, yes, clearly we've shown that the greater degree we can reduce it down to mild, even over moderate, the patients benefit. On the tricuspid side, the right ventricle is much more intimately connected with the tricuspid valve, I think, and RV dysfunction is harder for us to figure out. But I'm impressed with some of the things Becky has said, and I really more and more are buying into her 5 grades evaluation scheme, just because I think it's the degree of improvement. So even going from torrential down to severe, well, one could still say that's not good, but 2-grade reduction there in those patients, oftentimes I find they are symptomatically significantly better off. So there's a lot we're still learning for this, though.
Yeah, maybe one last question for Philippe. Do you sometimes bring the patients into the hospital a day or two early to maximally diurese them so you could get a better maybe post-procedure assessment? Or you just assume that they're optimally medically managed and you take them as is?
No, that's exactly what we're doing. The preparation of these patients is very important, because the majority of the patients who are referred for these sorts of procedures, they have borderline gaps or beyond. And if you manage to diurese them over a couple of days, we see tremendous reductions in gaps. So patients who were not treatable before from an anatomical point of view, they are fine, eventually then treatable. And that's a good opportunity to treat those patients with larger gaps.
Yeah, and I think that also sort of reflects a difference between tricuspid and mitral, where it's unusual to see that dramatic an effect from hospitalizing someone unless they have an extraordinarily high LVEDP pre-procedure due to heart failure.
Yeah, but it also shows how important it is that these patients are on optimal diuretics afterwards, and they should not be stopped after the procedure, because if those are the patients who come back very early and don't have a perfect result.
Yeah.
Sorry, Becky, continue, please.
Yeah, I think the next challenge really for us has always been intra-procedural imaging. And part of the reason why it's so much easier to image the mitral valve is that the esophagus is right next to the left atrium. And so with a little bit of right flexion and a little bit of retroflexion, you get yourself perfectly aligned over the dome of the left atrium, and it's just a no-brainer then from there to be imaging the mitral valve. And so we create these gorgeous images because we've now got the annulus perpendicular to our instination beam. And 3-dimensional imaging, 2-dimensional imaging, it's all pretty easy for the mitral side. But the tricuspid is so different. The leaflets are really, really thin, and there's many of them. As I showed you before, the esophagus is the furthest thing from the tricuspid valve, so it's really far away. And the plane of the annulus is just never going to be perpendicular in the mid-esophageal views. And so we've learned that there are multiple different levels that we have to use to image this valve, which is a really tough valve to image. And one of the most important ones is going to be this level B, which is a deep esophageal view, and then our levels C and D, which are transgastric views. And so again, you know, when we attempt to image the right heart, we're going to typically from a mid-esophageal view be imaging through the left heart to the tricuspid valve, and we can never get over the dome of the right atrium unless you perforate the esophagus, which we hope not to do. And so our alternative is just to push in a little deeper where we get closer to the tricuspid valve, and that is this distal or deep esophageal view where now we have no left atrium in our way. And so for those patients particularly that end up having left heart structures like replacements, then we can get away from the acoustic shadowing. And from any view that you get a really good look at the tricuspid valve, you can throw on 3D. And 3D really has been what's changed our lives with the tricuspid valve and the new software package. So these are the last two here from the shallow and the deep transgastric are using the real-time 3D MPR, which allows us to reorient the valve in any way we want in order to really, really see the leaflets better. And so three-dimensional imaging, absolutely key for us to do the mitral and tricuspid devices. Obviously for the mitral, we have to do a transeptal, but for the tricuspid, it's just coming in straight from the IVC and aiming down toward the tricuspid valve, so pretty easy. We can do all of our positioning either from similar biplane views. So for both mitral and tricuspid, we use what's called a commissural view on the mitral side, and this is also the equivalent of the commissural view on the tricuspid side. And then obviously using 3D to orient, and in particular using transgastrics to orient the tricuspid valve. I'm sure you'll see a lot more imaging by the other speakers looking at this device, which is the Pascal device, which has independent clasping, and you can really fine-tune the clasping either from these types of two-dimensional and biplane imaging, but what we really love for tricuspid is if we've got a good transgastric view, we just use our real-time 3D multiplanar, and it's just like, you know, looking through glass. So you can really see the leaflets into the clasps. You can see the clasps coming down. You know, you can really do almost the whole thing using three-dimensional imaging, which can align then you orthogonal to perfectly aligned really with the clip arms, the clasping arms, and the paddles. So I was going to end here and just say that 3D really has been our friend, and some of the advanced imaging that we're using now has really made a huge difference in technical success during the procedures.
Well, that was spectacular, Becky, and just a beautiful imaging. So maybe we'll just pause here, and if any of my colleagues have any, or panelists have any comments or questions for Becky.
So Becky, you know, I love the 3D live MPR. Do you think the quality is getting to a point now where we can just use that for the whole procedure when, you know, from getting out trajectory to actually seeing leaflet insertion? Because the previous versions, you kind of, when you really wanted to be sure leaflets were in, you kind of felt you needed to go back to the 2D, and it wasn't the quality you needed. What do you think that's changed and is changing?
Yeah, I mean, the last image I showed you was so clear because we were really close from the transgastric view. So super, super close. You're now using near field. You're don't have beam widening in the far field. But if we were to do the same thing from the mid-esophageal view, having to look through an atrium that's, you know, 10 centimeters, we're never going to get the same resolution. And so it's not necessarily, the equipment is definitely getting better. There's no question. And we've actually done entire procedures on 3D using, you know, looking for the grasping and the whole thing. And certainly for some of the devices like Evoke, we do entirely on real-time NPR because we're rotating around real-time to make sure all the anchors are in place. So yes, it's getting better and better, and we strive really hard as imagers to get you those images, understanding the limitations of physics and ultrasound physics.
All right, well, that was great. Maybe we'll move on to some data, and I'd like to introduce Dr. Scott Lim, who will give us an update on mitral valve therapy and the latest data. Scott.
Mark, thank you very much. I really want to focus this part of it on the data that we have from the most recent study. So on the MitraClip side of things for the mitral valve, it's the EXPAND study, which was presented at ACC, and for the Pascal side, it's the CLASP EFS study. So just give people a context, the MitraClip has evolved over time, and the most recent iteration is the G4. We don't fully have data on that yet, but I'll tell you about the previous generation NTR XTR data. And the key thing from my standpoint is that this study had an independent echo core lab with the same core lab involved in the previous MitraClip trials, Everest 2 and Realism. And I think that's really important because it then brought to light some interesting points about the data set here. And the patients we're looking at, there is, in this EXPAND study, there's over 1,000 patients consecutively consented and enrolled at a number of different institutions. Of them, the echo core lab adjudicated over 800 had adequate imaging, and about half and half were split between primary versus secondary MR. And the data we have that I'm showing you here is on MitraClip in primary MR, which does also include a few cases of mixed etiologies. But the key thing from the Echo Core Lab that first jumped out to me from this data, and I'd be curious to my colleagues' thoughts on this too, is that in order to get patients in the EXPAND study, every site, and these are very experienced mitral sites, had to adjudicate that they had severe 3 or 4 plus MR. But then after the fact, the Echo Core Lab reread those studies, and 2/3 of them, the Echo Core Lab adjudicated as having 3 or 4 plus MR, with fully 1/3 of patients having 2 plus or less degrees of MR. So I think this, to me, showed one of the challenges of mitral regurgitation assessment, and one of the imperatives of clinical trials is having an independent Echo Core laboratory.
Yeah, I'll just make a comment. We've seen that a number of times, and it's really important that the interventionalist in the cath lab doesn't let sort of the momentum carry him forward, because very often the imaging in the lab is at least in our hands, is significantly better than some of the imaging that we may be provided pre-procedure. And that may be due to the patient's discomfort or the ability to take more time doing the procedure or looking at the images. But having said that, we will often do some sort of manipulation in the cath lab to just make sure that we're accurately assessing the MR.
Yeah, I also would agree with that and add, and I think several of my echo colleagues have really been a proponent for quantitative assessment of MR, not just turn the color flow on and see how much of the left atrium is filled with this, but all the different quantitative indices, and then putting that together to give a final grade.
Yeah, I think that's the key to this, and why you had 30% of them actually not have severe mitral regurgitation, because remember, this is primary disease, so it's late systolic jets, and if you're just looking at jet area and the max jet area, you're going to call it severe, but it only occurs in half of systole, so it actually is only moderate. And so I think you're right, Scott. I mean, quantitation is key, and that again is a very nuanced task that we do, and has to be practiced all the time.
If you base your indication on an intraprocedural echo, is there a risk that under GA that MR might be lower than it is normally awake?
No, that's a really good point. I think there's two parts to that. One is, for this study at least, the indication for the procedure was based on the transthoracic or transesophageal done prior to the procedure. And then two, this is primary mitral valve disease, which I think is, unlike secondary mitral valve disease, is less affected by the effects of general anesthesia and dropping SVR. So the data we have from the EXPAND study is that this is a very safe procedure. Even in the early clinical trials to now, the rate that we're seeing of complications is quite small. One of the earlier concerns with this newer generation of MitraClip with the longer clip arms is that we may be at risk of injuring the mitral valve, because the longer clip arms act as like a longer or more powerful lever. And so while there was concerns by many of my colleagues about this, when that was independently adjudicated by a committee tasked to look at that, they found that less than 2% of patients had a single leaflet device attachment, and essentially only one patient had an actual leaflet injury. So leaflet injury is possible, but the rate at which it's occurring, though, is relatively rare. In terms of MR reduction, what we found here is we wanted to be fair and pulled out the patients that had less than 3 plus MR, and that's on the left side of the screen, and really just focused on the patients that had 3 or 4 plus MR at baseline. And the results by time of discharge and at 30 days are shown here. And I'm really gratified to see these rates that we're now getting in over 82% of patients reduction of MR to 1 plus or less, and fully 1/5 of patients were getting no residual MR at 30 days. And so these results now are starting to challenge the surgical outcomes, and I think are really giving us a lot more reassurance as we head into other clinical trials in lower risk patient strata, like the REPAIR-MR trial, which is randomizing in surgery. Not only that, But unlike in the earlier clinical trials, our colleagues are tackling much more complex anatomies, and the Echo Core Lab adjudicated that nearly a third of patients enrolled in the expanded study had complex anatomies where they had extremely wide prolapses or flails, calcification in the landing zone, or markedly degenerated leaflets. Despite that complexity, the outcomes in complex versus non-complex anatomies are fairly similar, with over 97% of patients in complex anatomies getting it down to 2+ or less, and nearly 80% to 1+ or less. So, it's not just one thing. It's not just the devices improved, but our understanding, our imaging, all of that has come together to really give much better outcomes for our patients here. Now, in terms of these newer devices, the XTR with the longer clip arms versus the NTR, we did find that the longer clip arm XTR variant was more often used in subjects with larger prolapse and flail gaps. And so this EXPAND study, I think, really adds to our confidence in terms of what the outcomes that we're getting, and really supports us moving forward with several other clinical trials in lower risk patient strata, in my opinion.
Very nice. Any comment from the panelists?
Yeah, I think the data is really reassuring, and shows that we're setting a new bar. I know we don't have any published data, but both Scott, you and Philip and Becky have had experience with the 2 new clip sizes now, with NTW and XTW. How is that fitting into your daily practice?
I'm finding that I'm using the wider clips much more common. And I think overall it means we're decreasing the number of clips we're placing in patients.
Yeah, I agree. I'm sorry, Becky, were you about to say something?
No, go ahead. I mean, that's our same experience. I mean, we're starting with the wide clip, and then deciding on XTR versus NTR based on the expand. Both cohorts were presented by Francesco Maisano, and it seems as though the primaries are the ones that we should be using the XTR on, and so we'll frequently start with if it's a functional, an NTW, to try and reduce the number of clips that we're putting in there.
Yeah,
and
the other piece there to it, Becky, too, is the wider the clip is, the more it'll distribute the forces on the mitral valve. So even though the rate of leaflet injury is small, I think it gives me at least a sense of more confidence that I'm less risking injury to the valve.
Yeah.
Yeah. I'll just add one additional point. We've also been fortunate to get a bunch of experience with the wider clips. I think the 2-clip procedures are less challenged with interclip or leaks between the 2 clips because of the broad shoulders of the W's. So I've noticed where I've done 2 clips that I am very satisfied in the fact that we are not seeing sometimes these leaks in between the clips, which has been really a big benefit.
But Mark, are you doing 2 NTWs or an NTW and an NT?
It depends on it's very often driven by the valve size, the gradient, and the expectation. And we're using, we're using the NTs a lot in the commissures or NTW, depending. Sort of like even the NTW in the commissure, just that I think the broader clip with the grippers still being the same, width has been somewhat advantageous.
Yeah, the leaflet stress thing is an interesting question, because I think the theory behind the Pascal is that with that broad paddle and the spacer, and then of course the frictional elements horizontal instead of vertical, that it should distribute the stress on the leaflet better than a narrow clip.
Well, that's a good segue. Let's
perfect.
Next part. Here's a nice picture of that. So the Pascal Device, as Becky's pointing out, has a much more broader, wider device, and it's a lot more rounded edges. And so the data we have on the use of this device, it is in the middle of a randomized clinical trial. So we don't have that data from class 2D or 2F. We do have from the early feasibility study of class, which is this here. And so we had the data flow is shown by here, and now we have over 50 patients with 1-year follow-up there. And the patients that were enrolling in class with the Pascal device is very similar to what you would expect. 2/3 were functional, 1/3 were degenerative. And the success rate for our colleagues with getting their hands for the first time on this device was reasonably high. And the average number of implants per patient was 1.4. The major adverse events shown here at 30 days and 1 year is gratifyingly low. Some of the complications, the bleeding ones, were related to the very small femoral arterial sheath just for pressure monitoring. And I don't think you need to do that anymore. And in terms of MR severity, the reduction, as you can see here, from baseline to 30 days, 6 months, and on the right side going out to a year is impressive as well, with 100% of patients, and this is core lab echo adjudicated, 100% of patients getting 2+ or less and 82% getting to 1+ or less. So virtually identical results compared to what we just showed with the EXPAND study in mitral clip. The concern, these are slightly bigger devices and perhaps they may create more of an inflow gradient as the device heals up, and the data we have going out years, no, it's a very durable and the mean gradients are stable. And so from this early study, we found some really good results in these patients in terms of MR reduction, improvements in their functional status and everything. And all that really has given rise to the randomized clinical trial of class 2 DNF, which will give us data on both primary and secondary MR types.
Yeah, I think the data is remarkable considering, we're always going to judge it compared to the mitral clip, which, it's been available for, more than 15 years. I think a lot of the acceleration of using mitral clip obviously occurred when imaging became, obviously much improved with 3D imaging. But I think these early results with the new technology are quite remarkable.
Yeah, I think the independent grasping is also something I've tend to use more and more that I'm comfortable with it, because when there's no longer I have these doubts, do I have enough anterior leaflet in there? It just becomes, no, I'm going to make sure I have enough anterior leaflet and just independently open up the anterior part, optimize, and go back down again. And I think it gives me a certain sense of security now, having the independent grasping, that I can get a better outcome. I don't know, Becky, what do you think is the image?
I mean, I 100% agree. We use it all the time. In the beginning, we would forget that we had it. And then we would say, oh, why didn't we optimize? And it turns out that, I believe that perhaps the lower clip number, so remember, they're only using on average 1.4 clips, which I think is interesting and I think lower than perhaps the other devices. Maybe because we're optimizing. We found that if we grab a little bit more leaflet, all of a sudden the mitral regurgitation goes away. So I think the optimization is really key. I don't know, Philip, if you also do that or have another technique.
Yeah, no, we pretty much do the same. At the beginning, we used it even more, the independent grasping. I think for the initial grasping, it's good to do it simultaneously, because the only downside of independent grasping is when you swing over from one leaflet to the other, you might get the clocking wrong, and thereby you can distort the anatomy. And to avoid that, what we now do is we do the first grasp simultaneously, and then we optimize each leaflet or the leaflet which needed.
Yeah, we've been spun by the cords occasionally if it's a big sort of swing to the other leaflet, which obviously is not optimal. Yeah. Well, that's, I'm sorry, Azim.
Yeah, no, I actually wanted to ask Philip, and Philip, forgive me if this is a slightly unfair question, but you're really the only one in this group who can answer this, right? You now have Pascal commercially available for the mitral valve in Europe. And at Leipzig, I know you do a lot of clips and a lot of Pascals. How do you choose? What pushes you to choose one device over the other?
I guess we're still in learning. We're certainly still in the learning. We have a sound experience, but it's still hard to say that this typical anatomy is much better with this device or the other. I think it will take a little bit longer and more data, and eventually we will know from the randomized trial comparing these two devices.
Okay, maybe I'll close this session or the mitral portion with one question for Becky, if you don't mind. Becky, integrating the hemodynamics, now that we have LA continuous pressure monitoring, has been, I think, very, very informative. And at the same time, I also want to ask, are we minimizing the role of pulmonary vein flow as well? Even earlier on when we were talking about, is it 2+ or 3+? I didn't see the integration of pulmonary venous flow, which I think really reflects what the patient will feel. So maybe you could help me with that.
It's 100% true. So there are two papers out there now. Both are very, very strong, showing that if you, one of the manuscripts comes out of Cedars-Sinai. It shows that if you just change the morphology, so if it was reversed, if it goes to blunted, or if it was blunted and it goes to systolic flow, that those patients are going to have a better outcome. And that manuscript went out to 2 years. And then there's another manuscript that shows that if the ratio of the systolic to diastolic velocity time integral is greater than 0.72, they've got a great outcome as well. So 100% we aggressively look at the pulmonary veins because we think that actually, not just intraprocedurally, but it's actually predictive of short and long-term outcomes.
Okay. All right, so we're going to now move over to Philippe, who is going to basically give us an update on the current data and devices for tricuspid valve therapy. And really a special thank you for staying up late to work with us on this webinar.
Yeah, thank you very much for the introduction and for having me. It's a great honor to share with you some updates on transcatheter tricuspid valve repair, focusing only on edge-to-edge techniques. These are my disclosures. So there are two devices for tricuspid valve edge-to-edge repair. First, the Triclip and the Pascal Device. Both devices entered clinical stage now in Europe. They received CE mark and they are assessed in clinical trials across the world. And I start with the Triclip. The Triclip obviously is an iteration of the MitraClip adjusted to the specific needs to approach the tricuspid valve. And specifically, as you can see here on the guide, now there are now two knobs because there are 2 degrees of freedom on the guide, and this facilitates to approach the tricuspid valve in a truly orthogonal trajectory, and that certainly helps when you dive through the valve. The device has been studied obviously in Triluminate trial, prospective single-arm multi-center study including 85 patients in 21 sites, both US and Europe. And here you can see the 1-year results. So interestingly, what we've seen early on, good reduction of TR was very well maintained at a 1-year follow-up. You can see that at 1-year follow-up, there was a high rate of patients with at least 1 grade reduction, 87%, and then 70% of patients were still had moderate or less tricuspid regurgitation at 1 year. Now, importantly, obviously, we would like to reduce TR, but what does that mean clinically? We don't have randomized data so far, but we have very positive early signals in terms of clinical benefit. You can see that these patients, they were less likely to be hospitalized for heart failure. So a 40% reduction comparing the 1 year before the procedure with the 1 year after the procedure. And this is specifically true for patients who had who had a procedural success, meaning that TR was reduced to moderate or less. That's the blue line on the Kaplan-Meier curve. So procedure success is really the key, bringing it down as much as possible. And then those patients will also benefit clinically. Now, this is an example of one of our patients. I think that was the first patient we treated with Intra-Luminate, a patient with severe TR. Probably we would refer to that also as atrial TR. You can see the transgastric views during the procedure. There was the main chat was anteroseptally. We placed 1 clip between the anterior and septal leaflet. Certainly not the most challenging anatomy, but here you can see what it looked like after 1 year. So we were very happy with that, very little TR, and the RV and DRA became smaller. So you can see that with appropriate patient selection, you can actually achieve quite durable results. Now moving on to the other device, the Pascal device, you've heard about it, specific features, most importantly, independent grasping. But in addition to that, the closure mechanism is also slightly different. With the mitral clip, you have a more active closing mechanism, whereas here, this is nitinol based. You have a passive closing mechanisms. And if we think about the specifics about tricuspid valve interventions, first, the leaflets are more or less see-through. They're very fragile, they're paper thin. And it might be that a more passive and atraumatic way to engage the leaflets on the device could be favorable. And the other issue, these patients, they very often present with larger gaps than what we normally see in the mitral valve. And there again, independent grasping is very useful. So this device was assessed in the CLASP TR-EFS trial, is still ongoing, again, multi-center, mainly in the US, and we see comparable degrees of reduction in tricuspid regurgitation, with 85% had at least one TR grade reduced at 30 days and 70 at least 2 TR grades reduction. These tricuspid edge-to-edge repair techniques, they're very safe. We almost see no complications. We also, and there was a big discussion at the very beginning, we hardly ever see RV failure. So that's also very good news. Overall, very safe procedure. Then I'll finish up with a case example. One of our patients we treated with a Pascal device. That's a 77-year-old lady, long-standing AFib, and again, something we would refer to as AFib TR or atrial TR. You see that tricuspid regurgitation was really massive, as shown in the middle, and then on the right, on this transgastric view, you also can see that there is an RV lead crossing the tricuspid valve, but this is right in the anteroseptal commissure. So in that case, not much contributing to TR, which is important when making decisions in these patients. So the strategy here, again, on a transgastric view, you can see that there is a gap really extending from the anteroseptal commissure towards the posterior commissure. And the feeling was that this requires 2 devices. And our approach was to start anteroseptally. We always have to start anteroseptally and then go posterior. Otherwise, you will get a lot of shattering on echo from the first device if you go the other way around. Transgastric views, you've heard about that. I'm obsessed with transgastric views when intervening on the tricuspid valve. I find it really absolutely crucial, and I hardly would ever approach patients where we will not get appropriate transgastric views. You can nicely appreciate the clocking of the device from 2 to 8 o'clock, which is appropriate when approaching the anterior and septal leaflet. Once this is assured, then we ask the echocardiographer to move up the probe again into the esophagus to get a proper grasping view. As you can see here, I think in this first approach, we did a simultaneous grasping, but you can appreciate that these leaflets are nicely in, and then if so, afterwards, the device is then closed. While closing, you'd like to see building up of tension on the leaflets, which is always a good sign that enough leaflet tissue is in. So after this, we released the device, and that was the result. Certainly a reduction, but we still had relevant TR, both anteroseptally and posteroseptally. We thought that anteroseptally we might have to accept, so we placed the next one posteroseptally according to our initial strategy. And again, on transgastric view, we make sure that the clocking is correct. You can see here that the device is not so much posteroseptally, but it's centrally, and it still approaches this intermediate leaflet or mural leaflet, we would like to call it. So in this case, the gap was a little bit larger. We had to do independent grasping, getting the anterior leaflet on first, and then swinging over to the septal leaflet, as shown here, you can see that before the device is closed, the septal leaflet is really touching the device, which is important to engage the leaflet safely and durable into the device, and then the device was closed.
Philippe, can I make a comment, a question actually?
Yes.
Yeah, so we've been using the Triclip for tricuspid and have had some really significant challenges. So could you speak to the importance of the angle of attack from the device, as well as what's beautiful here is that the anterior leaflet and the septal leaflet are in the same plane due to your angle of attack. But if it's at all different, like you have a septal hugger of your catheter, what I've noticed is that the anterior leaflet resides lower than the posterior leaflet as you're coming up. You're out of the plane. So not only are you swinging over, but you're swinging, you have to pull up. And we've had an SLD, a couple of SLDs, frankly, because of that.
We spend a lot of time into the RA before we cross the valve to make sure that we get the perfect trajectory. And when we use the Triclip off-label on the tricuspid side, sometimes that was the most important limitation of that device, which is much better now with the Triclip. And the same is true for the Pascal. With the correct steering and maneuvering of the guide and the steerable catheter, you can almost always avoid the septal hugging. So the key is really to spend a lot of time with getting the trajectory right.
I think that's a very important point. Scott, you're going to make a comment?
Yeah, because we, similarly to you all too, early on in our experience, when we didn't have a tricuspid specific device, we would use the Triclip off-label, but the delivery system is not optimized for putting on the tricuspid. So we would do all sorts of things, including intentionally miskeying the device to trying to get it to perform, to create the right trajectory. And in many cases, it is a much more challenging, at least in our hands, much more challenging experience. And that's why I would urge caution to many of my colleagues when we now have these tricuspid specific delivery systems, it's worth waiting for.
Absolutely. Becky, I know you have some thoughts about this as well.
Yeah, I mean, this is where, again, we've just fallen in love with real-time NPR because, you know, you can really line up the device inside the right atrium and get the angle of attack just right. Sometimes, you know, using just regular 2D, you know, depending on how horizontal the heart is or vertical, you may not get the best imaging, but if you use the 3D and line up the two views, orthogonal views, you can really get, you know, your anterior, posterior, and your septal lateral orientation and perfect the trajectory. But I agree that it's absolutely key. And then to Scott's point as well, just, you know, the new devices, the Triclip and delivery systems are just so much better than miskeying the Triclip that we would really, you know, hope that most people would refer to a center that's in the US that's doing one of these trials so that they can have the advantage of using these incredible delivery systems.
And Philippe, could you comment if you've had any issues with this or have thought through this? The second clip, if it's approximating the first already deployed clip, the risk of actually pulling the clip off because these leaflets are so thin.
There is a risk, especially if the first grasp was sort of acceptable but not perfect. I think it's important to manipulate as little as possible once you cross the valve. So before you cross the valve, make sure that you have an idea about the clocking, opening device maybe before and get the clocking right. And once you dived into the RV and you are in close proximity to the first clip, maneuver as little as possible.
Perfect.
We spend much more time in the RA than in the RV for these procedures.
Yeah.
You know, Mark, I think also we've got to be aware that because we're still early on in our experience with tricuspid edge to edge, we're still learning. The imaging is more challenging. The anatomy is different. That we are going to see more SLDAs than we're accustomed to now on the mitral side. And so, you know, trying to optimize all of this, the imaging, the trajectory, really taking your time to be sure there's leaflets, that you have good leaflet capture, and even trying to optimize is going to be especially important. the other group I get challenged with, and I still think we don't have the answer to, is, you know, the patients with pacemaker leads. And I think Philippe showed a great case there where the lead was just really out of the way in the commissure, and he had a great result. But I still think, you know, there's so much variability about where these leads are, and what will happen after you've put your devices in, that I think we still have a lot to learn about leads and TR.
Absolutely.
Maybe one last point I'd like to make about this case is that's the final result. So we're very happy, obviously, because we brought down TR grade 5 to TR grade 1. But maybe you noticed that before we implanted the second device, the amount of TR unperceptibly was larger than it is now. So, and that's something we see quite often, that you get an effect and TR reduction away from the site where you implanted the device. And this is due to the fact that one fundamental principle of this procedure to work is not just leaflet approximation, but also sort of an indirect annuloplasty. You reduce annular dimensions by pulling over the RV free wall towards the septum. And that's also the reason why it is important to, or at least we always do, that we connect either the anterior or the posterior leaflet to the septum, but always to the septum, because this is the most stable structure in the RV.
Yeah, we found that on the mitral side, just as an S side, often very dependent on clip orientation. I wonder if that's the same on the tricuspid.
Yes, but sometimes little changes can make actually a huge difference. But this is why I said I'm obsessed with transgastric views, because the clocking, again, absolutely crucial for procedural success.
Mm-hmm. Okay, well, that was superb. That's a great segue into tricuspid valve part 2, which we'll be speaking about Cardioband and Evoke and Azim.
Yeah, thank you. So thanks, Mark. We've been talking a lot about tricuspid edge to edge as one of the predominant techniques for repair. But I want to remind the viewers that we also do have an opportunity to perform annuloplasty directly on the tricuspid. And particularly, there are some cases that may benefit from this. We've been talking a lot about, Becky mentioned earlier in the session about, patients with more atrial TR that have annular dilatation, and possibly maybe this technique, either alone or in combination with edge to edge, may be potentially a very useful technique. So I was lucky enough when I worked in Europe to be involved in the TriRepair study, which was really the initial study to test the Cardioband device. For the viewers, if you remember, the Cardioband is a direct annuloplasty device. So you put this band in and you attach it to the annulus, starting really close to the anteroseptal commissure, and really doing the entire sort of free wall along the anterior leaflet, the posterior leaflet, past the posterior septal commissure and the coronary sinus, and getting high up onto the septum again. You attach the band using these anchors, and it's attached sequentially one by one. Once you have the entire band attached, as you see in the picture on the right, you can then cinch the annulus and reduce annular dimensions, and really see real time how these annular dimensions become reduced and how TR decreases. So maybe if you look at the next slide, I'm just going to briefly on the next slide highlight some of the clinical data. Most of the clinical data comes from the TriRepair study, which was the initial the initial study in Europe that led to commercial approval in Europe of the study. There's also a Cardioband EFS in the United States that Scott can give us maybe a little brief update when I finish this. So we do have data from TriRepair up to 2 years. You see that the device is really pretty safe. One of the concerns early on in the early experience that I wanted to point out was the risk of coronary issues. Remember that the annulus is very close to the right coronary artery. And early on, we learned that you had to be careful not to penetrate the right coronary artery, but also when you cinch, you can get kinking of the right coronary artery. And when we first saw this in the initial patients, we were extremely concerned, thinking that this could lead to long-term effects. What was interesting as we kept doing it, We learned that if you left it alone and rechecked the coronary angiogram in a few days, actually that kinking disappeared and the coronary artery returned back to its normal shape and form. But you'll see that 77% of patients had no events at 30 days. There's data up to 2 years showing that the reductions in TR are sustained. 36% of patients having mild, 36% having moderate 2 years. But once again, these are small groups of patients that have been followed up to 2 years. When you do reduce the TR, you do also see that patients feel symptomatically better with an improvement in NYHA class and an improvement in edema, and that they also get quality of life improvements with an increase in their 6-minute walk and their KCCQ. So that was the try repair data from Europe. I thought we could stop here and maybe hear the panel's thoughts on these data, and maybe Scott tell us where the EFS is right now.
Yeah, so the EFS in the United States is ongoing. We've completed the initial cohort and presented the data, and the data looks very similar to what you presented here, which it's a very safe procedure. And the reduction in TR is significant, albeit not perfect yet. As we've seen, similarly, patients improve symptomatically and their functional status. So I think however we reduce the TR, be it an annuloplasty or an edge-to-edge effect, in a significant number of patients, perhaps not all though, we are having a marked improvement for them. Like you, we also saw some issues of kinking of the right coronary artery that then, when you look 24 hours later, seem to have resolved. And it really calls to mind that when our surgical colleagues do a surgical tricuspid annuloplasty, we never look at the right coronary artery. But I wouldn't be surprised if there's also some short-term phenomenon going on there that doesn't appear to extend to any long-term issues.
Yeah, absolutely. I think one of the other areas that Cardioband helped us understand, we haven't discussed it on this webinar yet, as relates to imaging, is the utility of 3D ICE. And really it was with Cardioband, and I think particularly, operators such as you, such as Charlie Davidson, who started introducing 3D ICE catheters to really improve the visualization of the procedure and really see the anchor going into the annulus and staying close to the hinge point. That made me think about how, as we move forward in the field of tricuspid interventions, that if we have 3D ICE catheters that offer 3D MPR as well, live, it could really potentially make the imaging a lot quicker and a lot easier, particularly in those cases that, Becky, you mentioned about where you just large atria and you're so far away, or there's a mechanical mitral prosthesis that's blocking your view of the tricuspid. Becky, any comments?
Yeah, I mean, the Cardioband offered a particular, problem because, because it's coming all the way around the annulus, and at some point, it's necessarily going to acoustically shadow the echo because the echo's behind it. So as you come around, particularly, at the posterior side, somewhere around anchor 12 to, 14, maybe 11 to 15, something like that, you ended up having a lot of acoustic shadowing. You really need another imaging modality. And what's coming down the pike are these beautiful phased array 3D ICE probes. The one that Scott was using is a halo array, so had its own issues, I think, with acoustic noise and perhaps resolution. But the phased array ones that I've seen are going to look like a TEE probe. I mean, it's truly phenomenal, 90 by 90 sectors. And I think will change, again, the entire face of these interventions, particularly on the tricuspid side.
Yeah, absolutely. They're not available commercially yet. I just used one of them recently, I think the Novera catheter, and it was interesting. I was able, on an animal model and a cadaver model, to be able to do a transcatheter tricuspid valve replacement without any TE imaging and just using an ICE catheter. Yeah. So it just shows, I think, the potential of how this could grow. I mean, Becky, do you see it as an issue for TE and for echocardiographers, or do you think these two modalities can live side by side?
Oh, no, I think that, it's still very complementary. I think, there are obvious you know, I think there'll be cases where the 3D ICE probe may not give you exactly what you need. And again, for hemodynamics or very, very large sectors, you may not be able to get everything you want. So I do think that they'll still be very complementary. But indeed, if again, what I've seen also, Nuvera as well as other companies, they're really, really good. I mean, they will definitely be able to move some of these procedures into the conscious sedation phase, where we may not need to have patients asleep with the GA and TEE probe. So I think it'll be an advantage, particularly with these patients who end up having liver disease and renal disease, and you know, we've had our issues with trauma to the esophagus. So I think it will all be, you know, better if we have more imaging modalities.
So Azim, maybe one last question regarding Cardioband. If we lowered the threshold for success, meaning that we want to put the Cardioband to basically not allow any further dilatation, and then subsequently reduce the annulus modestly so that we could do a Pascal tricuspid clip, is that a reasonable approach, sort of this toolbox approach, as opposed to trying to make this a definitive procedure?
Yeah, that's a great question. I think, you know, Cardioband could be a definitive procedure if we move to earlier patients. So if we got to patients,
great point,
just that annular dilatation with moderate to severe TR without tethering, it might, I mean, we've seen that in the EFS in the US and the study in Europe, that if you get those patients who are early on in their course, they do extremely well with Cardioband. Now, I used to, you know, in the mitral, we've done combination annuloplasty and edge-to-edge, and it's worked extremely well. It's turned some patients who are not great edge-to-edge candidates into edge-to-edge candidates. And I wondered the same about the tricuspid. And initially, I would have, if you'd asked me this a year ago, I probably would have said yes, Mark. But if you ask me that now, I'm probably going to say that my next slide and devices such as the next slide are probably going to replace that technique. And I think that's a great segue into, I think, transcatheter tricuspid valve replacement, which to me on the tricuspid front is really, I think, going to be a really predominant technique moving forward. And here's a picture of the Evoque valve. This is a 28 French transfemoral system that, you know, can be implanted percutaneously with procedure times under an hour. Okay. Now, for anybody here who's done a Cardioband or who's done a difficult clip case, knows that procedure length is never an hour. And the other big thing is that residual TR is almost zero with these devices. They are extremely effective in eliminating TR. Scott, I'm gonna, you know, this is your patient. I'm gonna let you just tell us something about this patient and about this case, please.
Sure. So as a patient, as you can see, has some tricuspid pacing leads from her CRT device. And although that lead, just like Philip pointed out with the earlier case, we thought wasn't causative of the TR, but we were worried that it was going right by where we would need to do an edge-to-edge therapy. So this is one of the cases where we used the Evoque valve, and the deployment of it allowed us to simply push that out of the way without putting more strain on the leaflet, risking pulling it out, and then to deploy the valve. As you pointed out, Azim, this is a relatively quick, in terms of tricuspid interventions type procedure, where we're very much focused on deploying these anchors that are curling back around. And as Becky pointed out, we're using the MPR to spin around to all segments of the valve, making sure we're capturing each and every leaflet with all of those anchors of the valve, and then simply deployed. It was too relatively quick, about a 50-minute procedure.
And
I think you had some
I have to admit, you know, this, and you tell me also, Scott, if you agree, but putting this device in is not an imaging challenge, or not as much of a challenge as many of the leaflet devices. I mean, this is you get your great view, you throw on the 3D, and you just don't move. And as long as you can hold still and then rotate your 3D around, this valve is being implanted, you know. And so it's just one of those things that the timing was right, with the right software and the right, you know, the TEE imaging quality has gotten to the point where you can really put this device in, you know, well under an hour.
Scott, I think you had some echo images as well of the valve. Maybe you could share, and then I'll show the clinical data.
Actually, let me go back to, yeah, here's the echo images of this valve. And so this is, as Becky pointed out, this is the 3D reconstruction, and then you can change your imaging planes, and this is what it looks like in 2D. And then, and on the bottom left, you also get a sense of all the different anchors of it in trying to make sure that those are capturing the leaflets appropriately. And here's also with color. This particular case didn't have any PVL of significance, although
Spectacular result.
yeah, even on the tricuspid side, even if there is some small PVLs compared to the torrential amount of TR this patient had before, I think this gets a dramatic improvement, and this patient was able to up and walking around soon by the next day and home thereafter. So it was an impressive case.
This is the clinical data from the compassionate use experience, which is 25 cases. I mean, this is really the valve where there's the most experience for transfemoral implanted tricuspid valve. I think now, if you take these 25 cases, there's probably close to another 20 that have been treated as part of the EFS. So there are over 40 patients treated with this valve. So a large clinical experience. But with these 25 cases, you see a high success rate, technical success, 92%. There were 2 cases not successful, one because of a non-coaxial approach and one because of a low emplacement that was treated with a valve-in-valve implantation. But remember, this was the first initial clinical experience with this valve in the tricuspid. And then again, you see there the delivery system, so from the time of insertion of the delivery system to removal, a mean time of 68 minutes for these 25 procedures for a first-in-man device and procedure, but as short as 37 minutes. I mean, really phenomenal. And the longest procedure, 101 minutes. If we look at safety, extremely safe. No mortality at 30 days, no myocardial infarction or stroke at 30 days. There was a case of renal failure requiring hemodialysis and an 8% risk of conduction system disturbance requiring permanent pacemaker. And that probably highlights maybe one of the differences about replacement versus repair. We will see more conduction system disturbances requiring permanent pacemaker. But what's really the phenomenal part is the TR severity, which you'll see at the bottom, that really at 30 days, 90% of patients with 0 or 1+ TR. And that's really a phenomenal result with a mean grade of 3.2. And patients felt a lot better with 76% NYHA class 1 and 2. So I wanted to hear maybe some of your final thoughts on, we've talked a lot about repair. Here's some really interesting data on replacement. And maybe we'll go through one by one, starting with Philippe, and then maybe Becky and Scott.
This is very, very exciting and absolutely thrilling to see these results. And I mean, as said before, the strongest signal we've seen so far from patients who underwent interventional treatment of tricuspid regurgitation was the fact that those who had dramatic reduction in TR, they were almost all doing brilliantly. And if you have a technology and an intervention which enables you to bring down TR to 0, to really abolish it, but at the same time, this might be the only thing where we have to be cautious and look very thoroughly for, which is RV function afterwards. But if that does not affect RV function, then I think this will make a tremendous impact and change for those patients with tricuspid regurg.
Yeah, I think you're absolutely right. I mean, we've already seen, obviously there's been a lot more of these valves implanted recently, and we're beginning to understand more. We're doing RV strain before and after implantation of the Evoque valve. And there is a significant reduction in strain, and even though these patients feel really good. So perhaps it is just a numbers issue. However, the RV does indeed, the function goes down, similar to on the mitral side. You know, if you have it's hyperdynamic because it's so afterload reduced. And so once you put the valve in, the afterload goes way up. And so I think we will still have to fine tune our patient selection, understanding again the impact of removing all tricuspid regurgitation on these patients, and trying to find better ways of assessing the plasticity of the RV and its recoverability in order to really optimize the results for the transcatheter valve replacement devices.
Yeah, you know, I'm struck by the pacemaker rate of 8%, and granted it's a small number, but what it means is we're going to have to rely on our EP colleagues to help us in some ingenious ways to deal with that, to both identify it a priori, prevent it if we can, and then deal with it when it occurs, because the last thing we want to do is put a new lead across this valve that we just put in there. But I think this whole field is really exciting. I agree with Philippe, and we're going to be learning a lot.
Mark,
I guess my comment would be it's one of the cases where the field's enthusiasm and the results seem to be running in parallel. As I see this data and I think of the patients I'm treating or going to treat, I think about making sure I make the right decisions, because I never want to take anybody's options off the table. And if I don't think they're an ideal clip case or Pascal case, whichever device you're using, then maybe you should pause. Most of these TR patients are chronic patients, and just make sure they are ideal, because this data is early, and it really seems consistent and quite remarkable. So I think it's another revolution, or beyond the evolution in our field. It's just remarkable.
I think maybe some unanswered questions about replacement that we'll have to learn, and will only be by numbers, leaflet thickening and thrombus issues. Fortunately, I think majority of patients who we see with severe TR are in atrial fibrillation, so they'll be taking anticoagulation long-term in any case. And then also, I guess, durability on the right side.
Absolutely.
That will be compared to the left.
Absolutely. Well, I think with that,
maybe risk of endocarditis also something which need to be monitored very closely.
Absolutely.
Okay, I think with that we'll close or finish this webinar. I think there was a tremendous amount of data and imaging and thoughtful discussion, which I think is really going to continue to advance this exciting field. So my co-moderator is Dr. Lateeb, and maybe you want to officially close the session with a final comment.
Yeah, absolutely. Well, let me start by thanking our great panel, Becky, Philip, and Scott. Thank you for the presentations, the active discussion. I mean, we really went through a lot, if you think about it, in the webinar, from imaging mitral and tricuspid, looking at some of the new data for the newer clips, and for Pascal and the mitral, and then moving on to tricuspid and really getting an overview of where we stand with both edge to edge and some of the new replacement devices. I think we could be doing this for hours and hours. There's so much more to talk about as a result. Thinking about patient selection, which patients would benefit the most. We haven't talked about which patient, what anatomy would benefit from which of the devices we looked at. But I think we're still learning there, and there'll be more of these webinars in the future.